You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
So we'll start with case number 1, who's a 49-year-old male with hyperlipidemia. His blood pressure today is 151/95. You repeat it in the office, it's 146/88. Looking back, you see his office blood pressures over the past year range from 130 to 162 over 78 to 102. His BMI is 35. But he says, my home blood pressures are always fine. What is the next best step in management for this person? And I think you all have audience response clickers, so pick those up. Okay, so 18% prescribe amlodipine 5 milligrams once a day and follow up in a month. Discuss lifestyle modifications, advise him to lose 5 to 10 pounds and follow up in 3 months. No one selected referring to a hypertension specialist. I'm proud, thank you. 58% chose ask him to bring his home blood pressure cuff into the office within 2 to 4 weeks. My opinion, the best answer and the next best step for his management would be to ask him to bring his home blood pressure cuff into the office. And let's talk a little bit about why.
Can we go back to the original slide?
Sure thing. Original slide, he said.
Original, yeah. I want to make a copy. Okay. Oh. So right away you see that blood pressure cuff is mounted on the wall. That is just asking for trouble. I don't know if his blood pressure was taken with his feet dangling up in the air, but that's not how we should take blood pressure. And, I think we need to stop putting blood pressure cuffs on the wall. We need to have them on wheels, room to room, and we need to have oscillometric ambulatory blood pressure monitors. I know it's an expense, but it is, at least in adult medicine, that's what we recommend. In pediatrics, they're still using an auscultatory method in young and adolescents, but this is just,
It's terrible. Terrible, Jan. Okay. Aneroid, when was the last time that Aneroid device was calibrated? Who knows? Aneroid devices typically lose calibration very rapidly. This one is wall-mounted. They should be calibrated every 6 months. If you have one of those that wheels around from room to room, that should be calibrated probably every month. Raise your hand if you've calibrated or had an Aneroid device calibrated or have any idea when the blood pressure machines that you're using in your office have been calibrated. No. We not. Okay. Thank you for making that point, Jan. Okay. So just a little bit about out-of-office blood pressure monitoring, and this refers to both home blood pressure monitoring and 24-hour ambulatory blood pressure monitoring. The 2017 ACC/AHA guidelines recommend out-of-office blood pressure measurements to diagnose, confirm the diagnosis, and for titration of blood pressure-lowering medication, particularly in conjunction with telehealth or counseling or other clinical co-interventions. This echoes what the USPSTF, I think Dr. Tuttle pointed out, sometimes we're conflicted. Which guideline do we follow? Here, we do not have to be conflicted. Both the ACC/AHA and the USPSTF recommend using blood pressure measurements obtained outside of the clinical setting for diagnostic confirmation, in this case, before starting treatment. However, this leads us to a bit of a conundrum in terms of how do we know that the home blood pressure or the out-of-office blood pressure measurements are accurate? And what I have here is a graphic that's taken from Medivol. It's an international agency that provides accuracy recommendations for medical devices. They do glucometers, pulse oximeters. As of recently, January, there's about 4,500 different home blood pressure monitors that your patients could be purchasing, and 66% of them have no proven clinical accuracy data. And so if you put garbage in, you're going to get garbage out. The vast majority of blood pressure cuffs that are available for purchase may not, I'm not saying they aren't accurate, but we don't know that they're accurate. And so how do we advise patients to find an accurate home blood pressure cuff? Here in this country, we recommend going to the validated device listing. This is a website. There's a QR code here on your there or on the slides. It'll take you to the website, validatebp.org. It was a venture started around 2020 by the American Medical Association. They convened a group of hypertension enthusiasts who evaluated the home blood pressure devices and made sure that they met stringent international standards for device accuracy. I will say FDA cleared or approved for a blood pressure device means nothing. Nothing at all. FDA home blood pressure cuffs can't be FDA approved. They can be FDA cleared. There is a clearance process. And clearance applies to things that are considered low risk. So if you're trying to get a heart valve approved, it needs FDA approval. A blood pressure cuff, because there's limited safety concerns, doesn't meet the same criteria for FDA approval. And so you'll see on the box the device has been FDA cleared. That just means the patient's not going to hurt themselves by using it. That's all that means, the FDA clearance. So you don't want to go to Wirecutter. You don't want to go to the New York Times or the Consumer Reports. You want to go to this website, Validate BP. It separates blood pressure devices for office use, for home use, 24-hour. There's another registry that's an international registry. It's been around a little bit longer. It's called stridebp.org. Similar information, but this is how we advise patients to find a home blood pressure cuff we know is clinically accurate. Any comments from my panel on helping patients find blood pressure cuffs and blood pressure cuffs that they can afford?
Yeah, so that's the right place to point patients. Some patients don't want to go look at a website, and I don't like to make branded recommendations, but there are some commonly available stores, brand names that you can recommend. You just find out what in your community, what Walgreens is selling, or what CVS is selling, or what Walmart is selling, and then you or your nurse or someone in the clinic can give them some direction if they need some more specific direction than going to the website. The website is the objective way to do it. You're not supporting a for-profit company, but some patients need more guidance than that, and in most communities, there's not a wide variety of blood pressure monitors that are available, and so you can narrow it down for your patients. And the validation is critically important. Your patients need to understand that. The other thing, there are some of the companies that make good blood pressure monitors also make bad blood pressure monitors, and so you have to be careful about that.
So not just a brand name. You're saying check to make sure that the exact model.
Right. So all of us are asked a lot about cuffs that are not brachial cuffs, wrist cuffs. How about my new Apple Watch?
We'll cover that.
Is a brand?
We're going to get there.
Yeah.
We're going to get to that soon.
Okay. Yeah.
But maybe we could talk a little bit about the obesity epidemic and the fact that how many of your patients don't fit into standard size home blood pressure cuffs, right? How many of you had that problem? How do we advise patients to get around that? Any practical tips?
Yeah, so some of the companies that make blood pressure monitors, they don't have them available in the store. You have to order them, but have large cuffs, and that's in your patients who have large arms. It's important to guide them towards something that they can get a large cuff to measure their blood pressure. I always advise patients, if you're going to get a large cuff for yourself, have another size cuff around for other family members, so you don't want your 13-year-old grandchild to be using the huge cuff to measure blood pressure. And then just for wrist devices, the best advice is just stay away from them.
Too small of a cuff. Too small of a cuff overestimates your blood pressure, and too large of a cuff underestimates your blood pressure. So it's important to get a mid-arm circumference in centimeters. There are guides, and usually you need a thigh cuff when you're like 42 centimeters in size. And, it's more prevalent than we've seen. Some of them make interchangeable cuffs, and some of them make a type of adjustable cuff that can be done too, so you can tighten the cuff. But it's important.
I think a theme, at least for my recommendations, echoes a little bit what Dr. Jones said, which is, we're all creatures of habit. So figure out what works for you locally and then stick with that option. It just gives us confidence in what we're recommending. He's right. There's some of the devices on this website will help you find devices for extra large arm circumferences. There is a few brands that offer cuff sizes that go up to 52 centimeters, which is most standard cuffs cover up to 42 centimeters. But they are separately purchasable and they are really expensive. And some of the cuffs that are designed to have interchangeable cuffs are more expensive than the cheapest cuffs that are on this list. So unfortunately, a good cuff for somebody whose arm circumference is about 50 centimeters can cost about $125 compared to a standard high-quality cuff, which should be in the range of $35 or $40. And so that's a pretty substantial cost difference. See what you can find locally and what resources you can use to help patients get those. I mostly agree with Dr. Jones about the wrist cuffs. There is a single wrist cuff that's on this validated device registry. I think there's one. There may be two now. But the wrist cuffs, I will sometimes use in patients who really have extreme arm sizes. They can be used. They're so finicky, though, in terms of positioning. And you have to be careful about that full stop. But with a wrist device, you need to be even more careful. And I would have that patient bring their wrist cuff with them every single time and demonstrate how they're using it and make sure that it correlates with the office ratings that we're getting.
The other option for the very obese patient, who even the very largest size cuff for the brachial artery is not a fit. And there are some patients with a cone-shaped upper arm. It makes it hard to get the cuff placed. the National Heart, Lung, and Blood Institute had an advisory paper about this issue a few years ago, and you take measure the forearm and use a regular brachial cuff on the forearm and measure the blood pressure. Is measuring blood pressure in the wrist rather than in the brachial artery. It's not ideal, but it is more accurate than a cuff here in the brachial artery that doesn't fit.
Doesn't work.
But the mantra is the further you are from your heart, the less accurate it is. And if you're going to use a wrist device, I would try to use it in younger people, because older people have a lot of arteriolosclerosis, hardening of their arteries, and the wrists seem to be a little less accurate in older people than in younger people. But if you're going to do a wrist, of course, don't let them dangle. It has to be back up at heart's position, just like your arm is resting on at heart's position, just like, but finger is out. Finger, blood pressure, now. Too far away.
So let's move on to our next question. Let's presume we've gotten our patient an accurate blood pressure cuff, and now they're going to ask us, well, geez, how should I be checking my blood pressure at home? Do we tell them they should check it at varying times throughout the day? You really want to get a sense. Do they want to do it twice in the morning and twice in the evening? How about when they have symptoms, or 1 hour after taking their blood pressure medications? Okay, so another actually pretty decent spread here. So 30% chose varying times throughout the day. 62% chose twice in the morning and twice in the evening. Thank you for not selecting when they have symptoms. And then 1 hour after taking their blood pressure medications, 8% chose that option. So for me, the correct answer to this question, twice in the morning and twice in the evening. And we'll talk a little bit about more why that is. So here's the when and how not to check blood pressure. How many of you have seen this?
All the time.
Right? These get better and better. How about this? Yes. I have patients bring this in every week. This one's my fave. Look, she's got her sweet cat singing on there. This is what we're seeing day in and day out in our clinical practices, right? So rather than have them check it randomly, we really want a standardized process. And this is specific to medication titration. And I take time to explain the reason for this to patients. It doesn't mean that the blood pressure they check when they have a headache or when they feel dizzy or lightheaded is inaccurate. That's an accurate blood pressure in the moment. It's just not a blood pressure that I'm going to titrate their medication based on. So random glucose or blood sugars are just like random glucoses. Our blood pressure responds minute to minute. My blood pressure is higher up here right now than it was sitting down there. It responds to our environment, whether or not we've eaten, whether or not we've had caffeine, vaped, as we discussed earlier. And unless we tell them otherwise, patients are going to check their blood pressure when they have symptoms. So really, we want an A1C of blood pressure. We all feel very confident using A1Cs to titrate diabetes medicines. So we really want a standardized, reproducible process for medication titration, and that is having patients check their blood pressure twice a day in the morning and the evening, and using an average of 3 to 7 days, which I think has been covered here. Dr. Basile talked about his process. Actually, Dr. Tuttle, if I might ask you a question. Sometimes it comes up, people ask questions about when to check their blood pressure at home if they're on dialysis. Do you have opinions on how or when to have them check their blood pressure in those settings?
I think the non-dialysis days are going to be the best time because, well, it depends on what type of dialysis. So if you're talking about hemodialysis.
Sure. Hemodialysis specifically.
It'd be the non-dialysis days because during dialysis, we pull off a lot of fluid. A lot of times the blood pressure drops. Mm-hmm. Many times we'll hold their blood pressure medicine. It's highly variable based on individuals. And so that day off of dialysis is the most equilibrated day. For people on peritoneal dialysis, which can be either nighttime on a cycler. You don't do too much continuous ambulatory PD, but in those patients, it would be daily and similar to other individuals. So, most people now are on a cycler at night, so in the morning and then in the evening. So it depends on the type of dialysis, but most people are on hemodialysis. So for the standard answer, I would say on the non-dialysis days.
Excellent.
May I ask Dr. Tuttle a question? Dr. Tuttle, primary care needs to know this answer. If a patient on hemodialysis does not have a hypertensive emergency but has uncontrolled blood pressure, when they're in the primary care clinician's office, should the nephrologist who does the dialysis be responsible for the blood pressure?
Well, first off, I think it should be a team sport. Okay, but easier said than done. Usually, though, in people who are treated by hemodialysis, it's a volume issue. And that is a dialysis issue. And the thing that I hear a lot from colleagues in cardiology or primary care is, why don't you guys take more volume off? Now, sometimes that's not possible because they drop their blood pressure so much during the treatment. So it has to be highly individualized. To be honest with you, Jan, as a practical matter and as a nephrologist, I prefer to do it myself because of those issues of what goes on at dialysis, the volume management, whether or not we hold the medicines pre-dialysis or afterwards. But that said, other people may have different practice patterns. But I think most nephrologists want to manage the blood pressure in a dialysis patient. But I'm interested in your experiences in your local areas of practice.
I think the most important thing is communication. It all comes down to communication. I've got this, or if you're seen in my office and I think a change should be made, I'm going to reach out to you first and say, I'm worried our patient has X, Y, and Z. These are my thoughts. What do you think? So I think it comes down to communication. It's my decision.
A lot of people come off of blood pressure medicines once they're adequately dialyzed too. So again, we typically go to, are they adequately dialyzed? But you're right. I mean, other people are going to see them too, but I think it should be co-management. I would be uncomfortable with a lot of people messing with those blood pressure medicines when I'm responsible for dialyzing them in between. But that doesn't mean we can't co-manage them.
Right. No, I think it's all about communication. So I'll move on a little bit. These are some resources. These are things that I use every single day in my practice. This is a reference that's produced by the American Medical Association, American Heart Association, through a venture called Target BP. There's a QR code there for you to take you right to the website. This goes through all of those important steps to get the most accurate blood pressure measurement at home, and also applies to office settings as well. But it's broken down into preparation, positioning, and measuring. I want to call your attention to the number of languages that this is available in. It's available in English, Spanish, Chinese, Vietnamese. I don't know if it's sad to say, but I've made friends with the people at the AMA who do these. They're very open to feedback. And if you have a language that you feel like you need these resources in, email them. The more times they get that information, the more likely they are to have that information. This is a sister sort of resource. This is a home blood pressure log that I use for patient education. I had to cut off the top and the bottom for the size. You can see this is available in 15 different languages, all on this website. You can just select PDF, and there's a drop-down menu for all of the different languages. Thankfully, they provide it in English, so I know what's written there as well. And then it has space at the bottom, as you can see, for the average. And SMBP just stands for self-measured blood pressure. So when patients bring these in, I'll have them take pictures of this and send it to me through an electronic portal. I ask them if they're feeling kind to do the averaging for me, but I always at least do the sort of a gut check to make sure that the numbers add up. You can also, I learned, and I don't know if I'm allowed to say this or not, but you can use AI to average these if the patient doesn't do it. You can take this and put it into your favorite AI website and say, average these readings, and it will spit out a range, the high, the low, and an average. Again, make sure you do a little bit of a gut check to make sure, because they can hallucinate, but it has saved me many a time. Obviously, if you have other people in your office who could do this for you, they could also do the averaging. But we use this average of a minimum of 3 and ideally up to 6 days. Comments on that before we move on to cuffless or devices from the panel?
Nope.
Okay, so let's talk a little bit about wearable devices. This comes up a lot. It's come up already here today. There's watches, there's rings,
Toilets.
There's even a toilet seat. This is a company, I don't know if I'm proud to say or not, but it's from Boston. Their motto is monitoring your health behind the scenes. Just take a seat. We'll take it from here. That's their motto. So
the UACR while you're...
I don't know if you heard Dr. Tuttle, you could get the UACR at the same time. The UACR every time. Just think, I wonder if they could get a little dipstick that came out.
Yeah.
Brilliant.
Let's patent that.
We're going to quit our day jobs, Kathy. So I think Dr. Jones alluded to this a little bit. Are these ready for prime time yet? And they aren't quite, and I'm going to go through a few of the reasons why. But I am optimistic that in the next couple of years, hopefully these will be more accurate for clinical use. Many of those devices rely on photoplethysmography or PPG technology. Takes a lot of practice to say that word. We're going to go with PPG from here on out. You're familiar with that. It's the same technology that we use for pulse oximetry. It's a non-occlusive optical technology, and it measures pulsating blood volume changes either by illuminating tissue and measuring the light intensity through a photodetector, or and you can do it through fingers, but also a patch. And over there in the in this panel, you can see here is a patch. This is one of the devices that is actually available right now. There's major issues with this type of technology, and I can describe them in a little bit more detail, but they're subject to inaccuracies based on a number of different environmental factors. And so temperature, if you have vasoconstriction, all of a sudden the temperature in here is warm, it's cold, the blood flow that this is using to measure might be altered. Movement or motion can impact the accuracy of the readings that are obtained, which, in the joggers here might be an issue. But ironically, the ring versions, even typing, even that level of movement might impact the accuracy of the reading. And so if you're somebody who types for a living, you may be getting more inaccuracy. But even walking can impact the accuracy. So I'm also optimistic that maybe in the next couple of years we'll have better validation protocols for these devices, but at least for the current time, convenience does not equal accuracy, and this is really important to remember. And most of these, unfortunately, are no bueno. So we'll let that emoji speak for itself. So let's go back to our case. Our patient had a home blood pressure cuff. They used it properly, measured their blood pressure twice a day, every day for 3 to 7 days and sent you an average. You've confirmed the diagnosis of hypertension in that patient. What blood pressure readings do you use for medication titration? Your options are home, office, home and office, or a 24-hour ABPM. So again, for me, home blood pressure readings, although home and office would not be incorrect. Jan, Dr. Basile, why don't you take us through the thought process here?
Well, we used to think the 24-hour ABPM was the gold standard, but there have been actually 2 studies that show that home does replicate blood pressure and outcome as well, if not better, actually, than ABPM, which is surprising to many. You don't get the nocturnal information on home blood pressure readings. You don't want to wake people up, and you can't do it. But home blood pressure readings should be used to secure the diagnosis of hypertension and to make titration and decisions on blood pressure management. The rate of alert blood pressure elevation, either through improper preparation for the blood pressure in the office or white coat effect or white coat hypertension if they're not on medications, is higher than you think. It may be approaching 1/3. So we wrote a paper in 2020 on using home blood pressure or self-measured blood pressure. And I think that in the new guideline, like in the 2017 guideline, it embellished. Remember, this is a 2020 paper, but I think there's been this kind of evidence. It'll be interesting to see what they say in the new guideline. But I think you have to rely on home. Now, I have patients bring in their monitor. I ask them to take their blood pressure, and I like to see that their blood pressure is similar to the blood pressure I get. And they're seated, etc. When I go to our own medical school to get my medical care in the orthopedic clinic, I've had both hips replaced, full disclosure. They are asking me my pain score and my medication reconciliation as the cuff is being inflated. I would rather them, and this is an issue at our school, I would rather them not think they have to get the blood pressure, which is an inaccurate measurement. My systolic is 22 millimeters higher when I'm engaged than when I'm doing it properly. Now, some people will say, but don't you want to know what your blood pressure is when you're actually excited or moving or being engaged? Well, I'm not engaged all the time in my life, and in every clinical trial, we took blood pressure a certain way. We base everything we suggest on clinical trials, or mostly, or a little on observation. So why not reproduce exactly what we're doing in a clinical trial? So I use home readings. I don't like to use office readings, and I have to get my patients to take accurate home readings. Now, I'm proud to say that since 1992, the VA has been giving every veteran who has a diagnosis of hypertension a home cuff.
That's nice.
So that's fantastic.
Hopefully a validated home cuff.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.